Okay, let's see here. All right. Let me just say hi. Good morning, everyone, and thank you for joining me. Joining us this morning, actually, one of my colleagues, Sung Hae, will be actually checking the chat bar for questions as you type questions in. And I'm very excited, actually, to spend a little bit of time chatting with you, listening to your needs and sharing a little bit about how we have been trying to build tools to reduce the cost for students in their education and actually improve their education process. And I know many of the colleagues that I've spoken with, in the PTA education world, it's amazing all the things that you guys have to cover in such a short period of time. And so I'm especially excited to spend some time chatting with you about PhysioU and also your thoughts and challenges as we continue to educate the rehab team. And I'm very invested in trying to be able to improve that experience. And so I see a note from Sam about my background. So actually, I'm going to share my screen. I know many of you are in programs across the country. So let me introduce myself. So just as a heads up, I'm recording this webinar because there's many faculty who have emailed me and said, hey, I can't attend at this time. Could we watch a recording? So I've got that recorded and it will be up on our website for those of you who have colleagues who may want to watch it, or for the others who have made a point to let me know that they can't attend. So briefly, who am I? Because I think that's very important. I'm an associate professor at Azusa Pacific University. Just by the way, can everybody hear me? Is everybody able to hear me?
Yep.
Okay, perfect. And you can see my screen?
Yep.
Okay, great. So this is probably going on my 16th year at Azusa Pacific in the entry-level DPT program. I'm a teaching and learning fellow here at the university, and so I get to spend a lot of time thinking about why is it so hard to help really eager and smart students become clinicians. And I'm rubbing elbows with a lot of really brilliant teachers. So this has been a great privilege at the university. I teach at the Kaiser Orthopedic residency level, as well as manual therapy fellowship, really the spine fellowship for, the sports fellowship for Kaiser and the spine fellowship for USC, or University of Southern California. And we've spent actually the last 6 years thinking about building tools that we think this generation wants to learn with. And honestly, that we think may enhance the classroom in ways that all of us hope can occur. I'm also serving as the chair of the Institutional Review Board at Azusa Pacific University. So that's my main background. I've been speaking a lot at a combined sections meeting on a number of different areas. Many of our new apps that we're building are built around movement, because we think our profession should be built around tools that really help clinicians.
They're not going to do that.
Really help clinicians learn about movement. So let me see here. Okay, so what you see here is just a sampling of a literature review for a research project that we're working on, looking at technology and how we're integrating it in our program. And one of the key thoughts that came out of this article is that the implementation of technology can enhance learning by making the classroom more active and student-centered. And so I think you and I recognize as educators that standing in front of the classroom and delivering content, large amounts of content, that time we can often use for more interactive experiences that help students actually take the leap to becoming the clinician that we promised that they could become. And so meeting students at their level of comfort with technology can be the key to the whole puzzle. And so I've been very invested in thinking about this, trying these apps out that we're building. We've built apps in almost every key content area that I'll show you. And also, as part of this webinar, all of you will have full faculty access as well for you to try out and to see if it will be useful for your students. Any thoughts or comments or questions before I move on? Okay, so I'm just going to keep moving on. Feel free to keep some chats coming in. What is PhysioU? So when I first started teaching about 15 years ago, I wrote a little pocket guide, Pocket Orthopedics, in my attempt to begin to link special tests and clinical patterns and treatment-based classifications, to link them all together. And I thought, wow, that should take care of the problem. I get to write my own textbook. I get to use it for my class. And lo and behold, 3 quarters later, my students were still had no idea how to evaluate, treat, and prescribe home exercise programs. So they had no big picture. They knew all the skills, and I think this is a commonality among us teaching in PT and PTA. They know all the skills. They have no idea how to apply it. They have a major challenge in trying to pull it all together. And so I sat down in the cafeteria one day and started sketching, at the typical sketching on a napkin, and thinking about what would it mean if we could build an app that would break the boundaries of the sequential chapters, that would not be limited by page count, that would have text and video and audio so that students can learn with any learning style. What if, before I delivered the material to them in class, I could already allow them to play through it, talk themselves through, and begin to see the big picture of these common patients that they would see. And so we spent the next 5 years or so building, one at a time, the clinical pattern recognition orthopedic apps. And then we started going after the other content areas. You can see assistive devices. I'll show you this on the big screen in a second. Gait, range of motion MMT and palpation, cardiopulmonary rehab, neuro exam. We're hitting all the major content areas all in one place on their phone. It follows them from the beginning of their PTA program all the way into the clinic and is constantly being updated. Imagine if that was the resource for your students. So in our short time together, I wanted to cover some top 3 objectives. One, I want to share some common faculty challenges. So this is a summary from many of you have written in through our PhysioU faculty page, commented about different challenges that you have, expressed different needs, and we're constantly monitoring that and thinking about it and trying to figure out how do we build stuff to meet these challenges. And then building bridges with PhysioU, to share with you a little bit about how we are doing it at APU. This is really an evolving case study. We're building new things and trying new things and getting student feedback. And then and we're beginning to study it as well. And then sharing ideas and needs. How can PhysioU support your team, your specific needs as the PTA type of education and that curriculum, very compressed curriculum? We want to be a part of that journey and to be able to help and potentially collaborate to build cool things. So some common faculty issues. These are comments from faculty related to student learning and the challenges of teaching. And I think it's interesting to see them. The commonalities, I think, are very broad and very common among different faculty across the PTA curriculum. So students want to see every skill before they attempt to perform it. I remember in the early days, there would be like 7 or 10 iPads or iPhones up in the sky, recording from every single angle something that I'm presenting. The students weren't listening. They weren't watching. They were just trying to capture it because then they could look back at it later. And for that matter, think about all of these techniques that we want them to read about and figure out how to do when they could just watch it once. That's my view about video content, especially for a very manual-based, skill-based profession. So they don't look at, it's very hard to look at pictures. Students really, they don't read text in the lab books, right? A lot of my students have told me, I hope you know that many of us do not spend a lot of time reading. This was a comment from another professor just this morning who says, I can't get my students to read. right? And I guess one big question is, and I'm all for reading. I still have textbooks in my classroom. We've begun to trim a lot of them. The certain ones that we don't think that the app and our notes can do the job, we certainly have textbooks. I'm not at all against textbooks. I just think we can create an adjunct tool for our classroom that will really serve the students well. Sam has mentioned, just real quick, is this open source type of offering? So this is a one-time fee. Educational discount is 50% off. It's a one-time fee of $99, and they get all of the apps, including all the future apps. So we just tell faculty, hey, if there's any one textbook that you don't find to be that useful that you can get rid of, you've already accessed all of PhysioU for every single one of your students, and that's $99 for each student. And Sam mentions that this sounds like a version of the flipped classroom. Yes, I think the future of PT and PTA education must involve some form of flipped classroom. We have been flipped for about 3 to 4 years now, and I believe that time that you buy by having some of the very basic didactic information going into online means that you can play apps out together. And I'll show you samples of how I do this. The videos, we are working on the captioning. Eventually, the videos are going to be captioned eventually. Right now, it's just video, sound, and then text below. So that's from Seinfeld, yes. Okay. The other comment was too many resources, too much information, textbooks everywhere. I was sitting with a couple of my students recently, and they said, hey, Dr. Wong, the reality is the bulk of us are not buying the required and recommended text because it's so hard to learn that way. And so I was a little bit shocked. I said, even the required text you guys are not buying, don't you worry that that content you're going to miss out on? And they say, hey, look, the general gist that we've experienced in our program is that if we study hard on the notes and listen carefully in class, and we take our videos with our phone, we actually are doing okay. And we have so little time to cover all the reading that every professor wants us to do. I mean, I think there's a little bit of give and take. I think faculty will need to recognize, is what we think happening really happening, and is that effective? And when each of us require a text or two times 4 faculty every quarter, what is that total cost? And does that do the job that we're hoping to do? So actually, I'd like to just take a moment. Everyone can unmute themselves and just comment about these two couple of problems. Is there any comments, things that you've seen or thoughts about this?
I can say that our students really a lot of them aren't getting textbooks anymore. And in those that do, they don't really read them.
Right.
No.
Right. Agreed. And honestly, when I think about that, I thought, you know what? I wonder if that is not happening. Could I engage them in the classroom into a resource that will invite them to explore on their own and learn on their own, right? To take this active learning approach. And so, yeah, I feel that same way. Is I've been carefully thinking about and talking to a lot of faculty about what textbooks have you been ordering? Which ones are you using? It's a unique position to be in, to speak to so many faculty from the East Coast, Central, and West Coast, and to hear very similar comments. Mm-hmm. Any other thoughts? And some of you might be muted, so if you have a thought, make sure you unmute your microphone. Okay, well, let me move on then. And then please feel free to jump in any time. The amount of material to cover. Wow. So I can tell you, every single faculty meeting, we're like, there is not enough time to cover everything we need. So it feels like everything is a compromise. No less, I think, at the very back end of any course, where we've delivered the material, we wish we had an extra half quarter or half semester just to help the students integrate things. But it seems like every time we're just finishing our course, delivering the basic material that we think we need to cover, there's no time left to do the integration. We hope that it happens in the clinic, and you know how chaotic and busy the clinic is. And so this is a serious concern for me as well, which is why when Sam brought up, hey, this sounds like the flipped classroom, the flipped classroom means that you can perhaps buy yourself 25% more time in the class-ish, where you're not lecturing, but you're actually, in my case, playing through the app systematically. Every week I play through the app so that the students will get a 50,000-foot view of the common problems in the shoulder, the types of exam that's going to occur, the types of interventions that match the impairments, and we have conversations about therapeutic exercise, and we just allow ourselves to have these conversations on a regular basis. And in fact, we've bought a lot of time in our classroom to create these case study based experiences that we do every week. So this may be a little bit of a leap for many of you who are really compressed in time, but I think there's little things that we would be able to talk about as I continue to share a little. And of course, this large amounts of material to cover, the assimilating large amounts of material and knowing how to apply it versus memorizing it. I mean, look, every PT program and PTA program is still having the same, I think, a common problem, and that is once all that material's delivered, knowing how to apply it, that crux, right, the key thing that we wanted for our clinicians, very difficult to occur without case study based types of experiences, I think. And I really believe that these kind of things need to be done on a regular basis. So let's move on here. Keeping references current. So imagine 10 years later, actually 15 years later, my textbook that I wrote, Pocket Orthopedics, has not sold out of the warehouse yet. So when I request, hey, 15 years later, there's a lot of things that have changed. I'd like to rewrite that textbook. Like, yeah, no, not yet. We still need to sell out our stock. So I decided, hey, well, then I need a new medium to be able to deliver the latest evidence-based material. And that is why we started building these apps, because we are constantly refilming. And as faculty speak in, hey, would you add this new special test in? We just film it and pop it up into the cloud, and everyone has access to it. It changes the game of information delivery, especially in this ever-evolving medical profession. So, and meeting multiple learning style needs, I think that's really useful as well. Let me just take a moment here. Any other comments? I see Amanda writing here, our students read the textbooks, but I work to write guided reading questions. That's really good. I think that's very valuable to focus their readings, really to create context for what they're reading. And then that takes a lot of time. Yep. And I think actually it would be nice eventually to share these types of resources among faculty, that we don't have to reinvent the wheel all the time. So that would be a conversation. I think PhysioU eventually, as we continue to evolve our faculty group, we will start being able to release these types of reading guides and share these things. But yes, I think the comment would love to minimize text, that I think is a reasonable option, especially when the texts do not do the job well. Other comments?
So, Mike, Sam
Hi.
said earlier,
Yes.
He has no mic, but he said ditto everything you said, even at a PTA level.
Great. Okay.
And then Seinfeld said, Michael, you have created an amazing teaching and learning resource.
Oh,
Thank you.
yeah, absolutely. It's a pleasure. Any of the other faculty who might have some comments about challenges in the classroom that you guys have been facing? And make sure you unmute yourself when you try to speak. Okay, well then I'm going to keep rolling on. So that's some of the common problems. think about, I've been thinking about this a lot. Traditional silo-style learning, class by class. You get the textbook when you come to the class, and we're going to hit you with all this information, and then we're going to tell you you're going to pull it all together later. So, and I'm speaking from my own experience, believe me, and I have tried in so many ways to move this class. Before, I used to teach TheraX, Ortho 1, Ortho 2. Then I moved TheraX to the back because my students were complaining, why are you teaching us exercises? We have no idea why we're doing it and what it's linked to. So I switched it to the back. And now they said, how come when you're teaching us to evaluate impairments and do manual therapy treatments, you don't link the exercises right away? Why do we have to wait for another quarter? So, as faculty, it's almost like, hey, we're given the curriculum the way it's designed. And yes, it may not be perfect, but we have to deliver the material in small bits. So my thought, the reason why we built these apps is because I believe that you can build bridges ahead of time to content that they may already have snippets of it in their brain. A lot of them know a lot of things. It's just they have no way to link that content. I'll show you how we do it. So every new class is a desperate sprint for survival, right? A new content, tons of stuff, and the risk of failure. This is that learning environment that we've created. So we're going to expect that you pull it all together at the end at risk of failure. So think about what that means for deep learning and being able to take the time to integrate instead of gorge and regurgitate. So many of my classes I found were disconnected. The foundational content, gross anatomy, range of motion, MMT, the kids just popped it out of their brain when they came to ortho, when they came to neuro. All of my neuro instructors like, did you guys, the early instructors, did you guys teach MMT? Of course we taught MMT. They have no idea how to do the MMT, and this is only 2 quarters later. And so a lot of that, there's something missing between these foundational content and how it links to the clinical content. So, for example, now I know for many of your programs, you may do some type of functional anatomy or some type of pathology-based class. For us in gross anatomy, we are building bridges, and this is an email series actually that we can offer to all of our faculty. We auto-deliver emails that build the bridge between the source tissue. So let's say you're talking about shoulder joint this week. Okay, this doesn't even have to be gross anatomy. We link it to the range of motion, MMT, and Palpation app, right? So we're in gross anatomy, we're looking at the shoulder, we're talking about shoulder, and we invite the students to now go and look at this palpation stuff that we're going to do in lab. So you'll see in the range of motion MMT app that there's all the bony palpation and all this common soft tissue palpation. And these are really from comments from faculty. Hey, could you add that in there? Because that would be really useful for our students. Let me give you just a quick glimpse of what that looks like here. So if you go to PhysioU, later you guys will all have a login. Your email will be sent out with your login, and you sign in here. You will end up at our app suite. So here you'll see all the apps. And more will be coming. We have a lot. I'll share with you more that's coming. And so, for example, in the range of motion manual muscle test app, and we have an iPhone app and an Android app, so the students have this on all platforms. Their phone, their tablet, their laptop, it's with them wherever they go. Because I believe that their questions happen at all times. So having that resource to look things up is where that synthesis, the fusion happens. So, shoulder, you have palpation, bony landmarks. These are all videos with pictures and instructions. And then you have soft tissue palpation here. Common soft tissue palpation, the video, the instructions. And then here we just added this little bit in. We wanted to build a bridge back towards anatomy. So here's all your origin, insertion, innervation. Great, so all that fusion can take place. And by the way, all of this is really useful because we are going to be asking you to learn about range of motion and manual muscle test. So here's an end-feel video describing the end feels of the shoulder, and then here is your range of motion assessment in video with sound, as well as your landmarks, your end feels, and your normal ranges from AAOS and AMA. And some notes, some keys to reliability that the specialist clinician, one of our professors, said, hey, these are some thoughts that when you're in clinic, some things to keep in mind. So that's just a glimpse of the range of motion manual muscle test app. And you can see the manual muscle test. Here's your key muscles. Here's your 2 grades. If there are other textbooks that use alternate positions, we have tried to film the alternate positions. So you don't really have to completely follow exactly what we have. We've tried to follow the alternate positions when they are available. And so here you have the grade scale and the origin, insertion, and innervation. So that's just a glimpse of that's potentially a textbook that you may or may not have to have, because it's kind of hard to look at pictures and learn all this stuff, and this can follow them into the clinic all the way through. All right, so that is that. I'll bring you back into the app in a second here. Any questions about that? So we link gross anatomy to the palpation. This is just same thing, gross anatomy. They're linking it to the app, and here's the they can just watch the video. So what I'm trying to do is invite the students to begin to see why they're looking at this gross anatomy, why they're looking at these structures, and how this is going to translate into their skill set, and invite them to explore. So remember, all of these apps, the students have at the beginning of the program. They don't pick this up later as they go class to class. So now I can build bridges and create breadcrumbs to all this cool stuff that they can explore and contextualize their world. So gross anatomy to orthopedics, right? So here you see this opportunity to connect source tissues and structures. This might be your path class or your functional anatomy class, and link it to common clinical presentations. So a glimpse of that, let me show you here on our website. We'll give you a better glimpse of that. Every week, our students get an email series. It's automated, and we can automate that for you as well, wherever you see fit. So if I go to PhysioU, and if I go to Knowledge Central, here if I go to Knowledge, you'll see the anatomy series. So in the anatomy series, so let's say it's knee week, on Sunday, the students know that I do not need to study this, I can just enjoy it. And my goal is to begin to build the patterns that I will continue to build on as each quarter goes on. So Sunday, they basically get an email that says, hey, I know you're in the knee joint, you're studying about the knee. Would you be interested in seeing what these patients look like? So here's a little bit of prevalence data related to common knee pathologies. And here's some of the clinical practice guidelines that our program is based on. These are from JSPT. And by the way, here's a 1-minute video. So you can click right into the app. Here's knee osteoarthritis. Do you want to learn about that? I want you to know that this knee osteoarthritis is tied to this guideline-based concept called knee pain and mobility deficits. They don't know much about that yet, but I'm going to build on that. This is just a seed. So they'll click on that. And here we are in the app. Knee pain with mobility deficits or knee osteoarthrosis. The patient often reports progressively worsening weight-bearing pain and stiffness in the knee joint that may refer pain above and below the knee. Patient demonstrates difficulty with transitional movements from prolonged positions like sit to stand. Patient has difficulty with movements like squatting and walking. You note the patient's antalgic gait here and a loss of knee extension range of motion. So all I'm doing here is a 1-minute video. They can read a little more if they want. So here's some reported findings: morning stiffness, less than 30 minutes, diffuse tenderness, some common examination findings. And if they want to explore more, they could always go and see, I wonder what we would do in the exam. I wonder what they're doing in the exam. Oh, yeah, range of motion stuff. Or they could say, I wonder how you treat this thing. Oh, okay, well, you could go into interventions, and under manual therapy, well, two things. One, you could watch a clinical reasoning video, and this is me giving a mini PowerPoint that says, hey, when the knee is stiff, usually we try to unstiffen it with manual therapy and MOBs and range of motion exercises. And eventually we restore strength, but we restore mobility first. So when they explore a little, they'll say, oh, restoring knee extension mobility, got it. Here are some MOBs. Oh, I've seen that before. That makes sense. It fits a pattern. And that will be even more than I could hope that they would do, but you'll be surprised how many of them are exploring on their own. So that's email 1. So they can watch all these little videos, hamstring strain, IT band syndrome. Oh, I'm interested in that. I'm going to explore. My goal was to create an environment where they can explore on their own because we do not have enough time to do it for them all the time. So if you go back here on, so that's Sunday. On Monday, we have chosen 2 or 3 patterns that we think they would be interested in. Oh, I get it. So this is auto emailed to them. Remember, all of our students get this email in their inbox. Oh, IT band syndrome. Oh yeah, lateral knee pain. I have that problem. I wonder, here it's tied into the anatomy. Cool. Oh, and some special test that I might learn a quarter later, a semester later. I've seen that before. That makes sense. Or, oh yeah, I know about that. Great. So they can go in and explore it. They can watch it if they want. And my goal with this, again, you can see it just takes it directly into the app. And it's part of this tensor fascia lata IT band assessment. Oh, all these things. Thomas test, IT band palpation, all the reliability and sensitivity data. It's all here. Everything's cited to its PubMed abstract. And you can see here, this will be gone soon, but we're in the process of translating all of this. But all of this links directly to the PubMed abstract. So you can see that we've put in a lot of work to try to make this a very evidence-based tool. Again, my goal is this is a risk-free enjoyment of learning. Let me orient myself to the app. Let me connect dots to things I may have seen before or things I've experienced before because it makes me excited about learning. So every week they are going to get the patterns on Sunday and 3 conditions: IT band syndrome, ACL sprain, and meniscal tear. Boom. Covers most of the common stuff. Monday, Wednesday, Friday, done. And they can expect that every week. So we've automated that. The instructor never has to think about doing this. It looks like someone just mentioned, when you bring this assignment back into class, let me go back to my PowerPoint. When you bring this assignment back to class, what is your primary focus? This assignment, because I know I'm doing this in conjunction with the anatomy instructor, they said, look, Mike, I have no time to do that. I said, I totally get it. That's why I'm automating this email series. It is purely adjunct learning that invites the student into this resource that allows them to contextualize the things that they're learning about. So I guess my point that I'm trying to make is, in this moment when we deliver this email series, there is no in-class assignment. It is purely inviting them to expand their clinical patterns, recognize the types of patients that are coming in, and begin to get glimpses into the apps to know that they can come here to sort themselves out when we start delivering content at a high rate. So we believe in building the patterns from the beginning and linking the anatomy to the orthopedic skill. So in the ACL particular anatomy series, you'll see that there's a link to a Lockman's test. Just like you saw IT band, there's a link to Ober's test. We do the same thing. You're talking about cardiopulmonary. Well, here's the heart, here's the lungs, and by the way, right in the cardiopulm app, we have these patients with the most common patterns talking about, and let me show you that, talking about, let's see here. I'm going to go back here. I'm going to go to cardiopulmonary rehab, and the students will just be directed to watch this video of this patient.
Well, I have been fairly active all my life, but lately I have been so tired and so weak. And what frightens me most is my legs and my feet have been swelling. And I'm having a little trouble breathing too. I need 3 pillows to sleep at night. I've had high blood pressure for a long time, and my doctor has given me medication for that, but sometimes I forget to take it and back often.
So imagine if these types of cameos, these patient presentations, are the seed of your active discussions in class. The physical exam, the objective tests that you would do related to this patient, they're all filmed here for you. Peripheral edema assessment is specific to this condition, so you can look at that with the students. They have this resource. Or the interventions related to the stuff that you guys are all teaching in class, they're all here. Inspiratory muscle trainer, progressive resistive exercises, patient education, all the common things. We built this with our cardiopulm instructor. Everything that she teaches is in this app. It allows the students to contextualize and to connect things to patient patterns. So that is kind of how we're doing this link from anatomy or functional anatomy to the clinical classes. So you can see, talking about the lungs, here you can go straight to the video and look at breath sounds. And the students can look at this anytime they want. This is how we build those email series. We first build them in the Microsoft Word, and then we program them into HTML and then deliver them as emails. We do the same thing for neuroanatomy. So the neuro exam app, if you think about, so we're building this Parkinson's disease particular email series so that when we're doing neuroanatomy, we're linking it to the common diseases and we're showing them the common tests. So if you think about the neuro exam, all the tests that you need to teach the students, every neuro exam test that you will ever teach is now built into this app. Okay, so here's your balance test. So we can go Berg balance, timed up and go. You can watch the video. You can tell the students, hey guys, before class, we're doing balance this week. Please watch these 5 videos. And then we're going to try these out in class. Everybody take your phone, take your tablet, go practice it. So here's the test. Here's the video of how it's performed.
For the timed up and go test, begin with your patient seated in a chair.
She is the director of the Casa Colina Neuro Rehab Residency. And you can see that here are the grade scores and the cutoff scores for fall risk and the citations. So pretty much every test for neuro is in here. Diagnosis specific, vestibular test, your vestibular exam, your stroke test, spinal cord injury test, Fugl-Meyer, stream, all of it has been filmed for you. And it just follows the student. I mean, who can remember all of this? It's in your phone. The students can revisit it anytime that they need. You can imagine my excitement when we finish building this particular app. Let me take a moment here just to stop and take some questions. Any comments or questions so far?
So, Mike,
Yes.
Sam commented earlier, say, great stuff. Would it be possible to segment your offering to exclude the PT eval parts for PTA's use?
Yes, I think eventually, Sam, that will be something that we'll be able to do. Right now, we aren't able to. And part of my thoughts is actually, it's kind of useful. Correct me if I'm wrong. It would be kind of useful to get the big picture of the things that are happening in the evaluation and how they link to the interventions. So I always think about when I'm working with my PTA colleagues, I wonder if instead of just looking at the order of things that need to be done, I think all PTAs are trained to look at the eval and get a good picture of what was done, why it was interpreted as such, and therefore, here are the treatments and exercise interventions that are tied to the entire pattern. So I wonder if that's that, to me, that's the biggest thing. And I think Seinfeld here says, yes, that's what you are thinking about, PTAs needing that big picture. Okay, so for example, yes, I just mentioned here that we're talking about techniques for labs. This is essentially my lab manual. And I think a lot of the techniques that we put into the apps are going to be this very similar techniques for what you guys are teaching in the same class. I'm going to skip to, just because we are on that topic, let me give you an example. So it's very clear that when a patient has frozen shoulder, so look at the pain pattern. So this is what we do. Imagine this is what I do every Tuesday, where I used to have 5 hours to lecture. I actually only lecture for an hour or two. And all of that lecture is actually interactive. I'm talking about common diagnoses, basically, is what I'm doing during those 2 hours. So about prevalence, about signs and symptoms, about common impairments. The last 3 hours, actually, I spent at least an hour just going through the patterns, like what I'm going to do with you right now. So, guys, for shoulder, there's 3 main types of shoulder problems. I'm going to simplify it. There's the shoulders that are mobility deficits. They're stuck. There's shoulder pain with movement coordination impairment. They have a hard time staying in the middle. They're unstable. And then there's this shoulder pain with muscle power deficits. They're impinged, right? They're painful, going up, generating tension. They're painful, subacromial pain syndrome. So in the case of mobility deficits, my students, and I think this is one thing that I think is very powerful, this idea about mobility deficits is a term and a rehab concept that translates from joint to joint. So from the very day one of ortho, beginning of ortho, my students will recognize that some people come in with disability and functional limitations because they have mobility deficits in whatever joint that they're coming in for. That could be a stiff knee, a stiff hip, a post-traumatic elbow stiffness, a frozen shoulder. And the expectation of the rehab professional is that we would examine range, examine accessory mobility, and actually let's just look at it. Examine range, key findings. Here we are in the physical exam. Examine range, physiologic range, and accessory mobility. That is the exam for a frozen shoulder at its most basic level. Okay. Now, at the same time, you will see that we have associated impairments. Many people have a really stiff thorax that you're going to want to examine the posture and try to treat that. And I don't think in this case we added any movement faults. So we have some very basic movement faults. People shrugging their shoulder early during elevation. All right. So, and then here's your differential diagnosis. Hey, if this patient's age under 40, they're more likely to be unstable. That's from the guidelines. If they have full pain-free range of motion, they probably are not frozen. And you probably, the clinician is probably thinking about clearing the cervical spine, clearing the thoracic spine. And if the PTA says, I wonder what they did, oh, they probably did Sperlings or some PAs or some quadrant exam. Great. So to me, that's one of the values, as Seinfeld had mentioned, that the PTAs can go in quickly and go, oh, this is part of the differential. No wonder those findings are there. This is how he determined that the primary problem is part of the shoulder, not coming from the neck. I mean, think about how potentially powerful that is. Hey, this person has a lot of shoulder pain. By the way, here's that upper limb neurodynamic test that we would have done at a low angle, right, arm by side, to test if this severe shoulder pain is nerve related. I mean, the depth of it can be a little bit daunting, but remember that all of this is kind of sorted out in big categories. Key findings, specifically to movement mobility deficits, associated impairments, common other things, the secondary drivers, and then some common movement faults, as well as, hey, what would you do to differentiate other conditions? This is the big picture that I think would be really powerful for the PTA and PT team to be unified on, right? So that's why I'm excited, especially to talk to the PTA group, because I always talk to my own PTAs that I work with, and it's hard for them to know what is all this data on the eval sheet. How does this what does all of this mean? This is where that can happen. And you can see, so for the frozen shoulder, I will ask the students, guys, how many of you have seen frozen shoulder before? 25% of the class will have seen it or had a family member who has it. What did they do in PT for it? Oh, they mobed it, they stretched it. Does that fit what you would do for someone with mobility deficits? Oh, that totally makes sense. The person's stiff. They can't function in life because they don't have enough range. When I tested strength, the strength was strong. So I need to restore range. Great. The cool thing about the apps is we can now organize the treatments and stratify it based on high irritability or low irritability. So you can see when the patient's really irritable, we're like, hey, just do some gentle stuff. This is what you do for the pain-limited patient. Great. Some grade 1, 2 gentle oscillations, some deep pressure to the muscles. But if they're less irritable, hey, I'm going to start doing some glides. Great. So what you don't see here yet is a lot of rotator cuff strengthening, because you don't need to do that yet. That's not the primary deficit, the primary impairment. When you move on into therapeutic exercises, we've organized the exercises based on irritability. Great. So pendulums in the early phases. Or in the more moderate phases, I can start using my pulleys and my cane exercises. Again, what you're seeing is my attempt to organize lots of content and tie it to patient patterns so that the students can now see patients, recognize the pattern, and do something relevant, not just do the standard menu of things that are floating around in their mind. So, and for that matter, we also have patient education. Everything is graded based on its evidence from the guidelines. And we basically have linked the JOSPT patient perspectives that they can actually deliver to their patients if they want. What can a physical therapist do for my painful and stiff shoulder? And every single one of my students will tell the patient, here's what's going on in layman's terms. Here's how long it will take. Here's what we're going to do in physical therapy. And here's what you can do to help yourself. So all of my students read this and then they modify it, but they have some background and some basis so that what they're talking about is generally similar. Of course, modalities, if they are appropriate in the guidelines, we have put those modalities in there. That is a glimpse actually at the orthopedic app. I do that every week of ortho. We are in shoulder week. We are going to talk about the main shoulder diagnoses: AC joint sprain, frozen shoulder, slap lesion or labral tear, some kind of instability, and then a subacromial pain syndrome shoulder impingement. We are going to walk through those patterns. I'm going to chat with you about it. It allows you as the clinician to actually weave together your clinical expertise and guide them through the thinking. And then on Thursday and Friday, when I teach them the techniques, everything already has a place in their mind. Everything has a pattern. So it's not just all floating in there. Comments about that? Thoughts?
There's earlier comments from Debbie.
Yes.
Love this neuro apps. Have you developed a pediatric specific app?
Yes, I will get to that towards the end. And then I see Seinfeld also talking about the big picture. Thank you. Any other comments from the team?
And another comment from Sam. The FSBPT met with our OHPT and PTA chairs about 10 years ago, and one school was moving the direction that you were going, but the test questions are based upon the very text that we want to minimize.
Correct. So many faculty actually I've been talking to recently have been talking about, you know what, do I really need Kisner and Colby to teach therapeutic exercises? Do I really need McGee to teach all the special tests? I will tell you that we have not used those textbooks in the last 10 years. And again, I'm not trying to say certain textbooks do not serve the purpose well. For me, I did not need that many special tests. it created a major problem for my students. They became special test heavy. They didn't know what to do besides that. In fact, all we've done for the special test, if you look at think about how crazy shoulder lab always is. Well, all the special tests, the best ones, as we've talked to the guideline writers, here's your instability test, 3 of them. All of it with your research information here. And video with instructions and citations. Here is your labral tear test. Here is, those are the tests. That's all we're going to teach for shoulder instability. So the adjunct, if you think about, will someone carry that textbook in with them? I will tell you that in the last 2 years, we have had 100% first-time pass rate. We are not having problems because between our notes and the app, we are getting clinicians who can think on the back end of the class. I would invite you to consider. Now, there are faculty who write back to me and say, hey, you took out this special test, the Apley test for the knee in the meniscal category. Well, because we had Thessaly's, we had McMurray's, and we had joint line palpation. But they said, yeah, but we think that one's still on the boards. And so I said, you know what? This summer we're going to film it and we'll add it back in. But our goal here was we would take the best test. We would, if there are ones that you feel strongly that you must introduce, then it's okay to introduce it separately. But part of the problem, right, that our students are having is too much volume. They can't handle it and they don't know what to do with it. So, yes, I believe that when you can create clinicians who can think and you give them the basic information that they need, they can pass the boards. And that's what we're showing in our program. So I think that's a very good comment. Any other comments from the faculty?
And another one from V. LeBond.
Yes.
As a PTA educator, I have the same concern that Sam presents. Do you have any evidence that NPTE scores are trending in a positive direction with the use of your product?
So, could you read that again? Sorry. Could you say that again?
As a PTA educator, I have the same concern that Sam's presents.
Yes.
Do you have any evidence that NPTE scores are trending in a positive direction with the use of your product?
This, I will tell you that we have not been able to study that yet because it is a very difficult thing to study if you can imagine how many variables you're trying to control. What I would say, my dream for this app is not to replace textbooks. If there's 1 or 2 that you can replace, great, because the students will enjoy learning. For example, will enjoy learning about gait more because they can actually look at gait in real time, right? Range of motion or EMG, let's say. So there may be certain textbooks that we can do better with the apps. My goal really with these apps is to help create clinicians. And I think clinicians pass boards better. And we know that our students are functioning at a very high level based on the CI's comments relative to our local schools. I think a lot of it is because we're using a lot of this to create context and give them stepping stones towards clinical practice. So I will admit that it is very difficult to study. I would love to be able to say it increased board scores. We are actually going to start releasing a quiz component where students, as they're using the app, will get quizzes related to the area that they're playing, and it will begin to prepare their mind for testing. But I will not go so far as to say this is going to be what takes your NPTE board pass rate to 100%. I will say it has worked very well for us, and that it is admittedly very difficult to study because it's very difficult to have a control group and to actually cancel out all of the other variables that go into how do you pass the boards. But I think it's an important thing. We are working with other educators on how to study this. Currently, we're running in a program assessment /study on what this will be like as a bridge into the clinic, because the CIs can now see the test as we are showing them. and see the pathway that the students are thinking and be able to have this unified platform to look at. Sam, let's see. Rodriguez, I think, okay, you are finding success without textbooks. Actually, we have textbooks too. Yes, that's Leona, yes. We have textbooks too. We're not getting rid of textbooks. We're minimizing certain textbooks because the apps and our notes can do the job well. And I think another good example of that, so Gait App, I think, is a good example of that. So you can study gait at a very basic level. We think when you look at movement, you need to look at it statically, but it needs to be on a human. And here's your range of motion graph, your EMG graph, and your critical events, so that you can talk together about things. And when you're done learning these static phases, you go into analyze, and now you have the normal, the different views, regular speed or slow motion, real-time range of motion. So we use real-time range of motion sensors and EMG sensors. And we have deviations of real patients. So it's very difficult to teach someone what a varus thrust looks like, but much easier when you look at someone with knee osteoarthritis. So I'm going to slow that down. And on her right leg, you can see that varus thrust there. And so the information here, risk factors, the penalty of this type of deviation, the cause, the associated phase, and we've also built case studies. Since we had these patients in already, we have all of these little cases that now that they've learned to do gait analysis, here is someone who has shin splints. Let's look at her from different angles, and here's her history. And let's talk about what you see. So this is the real time. This is the slow speed. Let me see, actually. There we go. And we will have these conversations. This is a very early class for us in the program, but we will have conversations like, what do you think about anything at the hip joint, knee joint, anything you might want to examine? They'll just begin to think, begin to expand their mind. Let me see. Yes, so that's the Gait app and the different views. One caution, sorry to bring up, our clinicians may not always allow our students to use their mobiles in the clinic. Yes, so I'm about to have a conversation with a bunch of our CIs who have signed up for our study. One of the things we've invited them to, we've told them that our students have been told that it is not appropriate to use their phone with the patients unless they are filming the patient to show them something or to show them some deviation, movement deviation. So we prime the CIs to know that they are using apps, and the CIs are actually being given these apps to actually play with so that they can actually see that this tool can be used as something that creates a baseline communication center spot for people to talk about. So I think that's really important, Sam, as well, that there is going to be this change in the way that we create manners for our students on the front end, and also begin to have conversations with our CIs, because this is a powerful tool. Our students talk about using this before the patient comes in. They're looking at the notes, they're planning the treatment, they're planning the next treatment, and they're kind of sorting themselves out looking through the app. So in our last 5 minutes or so, let me just close off by saying we have built the Assistive Devices app. This app has all your assistive device fitting videos, gait patterns with all the assistive devices, with the right leg and the left leg involved. So you can see here's the preparation video, here's 4-point gait, modified 4-point gait, and then you get to watch the video, and you have a right leg affected and a left leg affected video. You can share that with your patients. And in that particular app as well, let me show you real quick. We have bed mobility and stairs, descending, lead with involved leg, ascending, axillary crutches, left extremity, right extremity, affected and non-weight bearing. So now your clinician can say, hey, I just showed you this. I'm going to send this as an email to you, to the patient, so that you can remember how to get up and down the stairs. So we are now beginning to build it so that you can use it as a clinical tool for your patients. Transfers, sit to stand, stand to sit, all of it. Remember, we were looking at the textbook and I said, that is so hard to learn how to do a stand pivot transfer looking at 5 pictures and reading the text. They could just watch it once and boom, they got it and they can go practice it. Imagine that, right? So someone mentioned the PEDS app. We've got 2 months left to film. Here is actually that's our modalities app. On a spur of the moment, I started building the modalities app. But we are filming babies. We have actually multiple babies, and then we're following the same baby every month of their first year of life. So you can see that this is how I design these things. I sit down with the instructor and I go, let's build something cool. So here's the different months. Here's how we would look at the babies in supine. And we're going to focus in on looking at the upper extremities. And here's a little video of some key things that we're looking for. And you can jump from month to month. So that's the PEDS app. It's coming. Of course, we're waiting for the babies to kind of... we've got 10 months out of the 12. And we're almost there. So that's the PEDS app. The modalities app I was kind of excited about. I started building this last week. So here is the, actually, sorry, let me find it. Modalities app. Look, modalities doesn't change that much. So what have I put the most common modalities? So you click thermotherapy. I'm going to click, let's say, hot pack. And here's the indications. A little video. In fact, I may just scrap the video. No one wants to watch me talking about hot packs. I'm going to put 5 pictures that they can just scroll through real quick so they can remember how to put the traction belt on for the traction machine. Here's contraindications. Oops, let me go here. Contraindications, precautions, application. You can see the text is changing here. How to do it, adverse events, and flip through the pictures. So I am thinking and dreaming. This is how I explore. This is what our students will use as they're in the clinic. And I think because they have this type of tool, they will be able to, that learning gets deeper and more automatic because they have the tool with them in that moment when they needed it, right? That's really where the valuable learning occurs. So let me just close out here and then open up. I know we're coming to a close here. Let me just say that we really believe that students can learn beyond the boundaries of the curriculum. I really think it's valuable this tool can be valuable because the PTA can see the big picture, can see a lot of the testing that goes on and how it links to the impairments and the treatments, the manual therapy treatments. I already did these couple of app demos here for you. And we've talked about the Gait Analysis app as well, and how we've built these case studies for you to use. And we are working with a lot of universities who are using it, testing it out, giving us feedback. There's a learning curve. The apps are not magic in and of themselves. I think there's a conversation to be had. And yes, exactly. I'll get to that comment in just a second, but we are learning ourselves how to best utilize this, and we're finding that it's important for the instructor to use it even in little bits on a regular basis, because students feel there's this power discrepancy where they don't feel free to do whatever they want, and honestly, they don't have time. So when I say, guys, I want you, before Thursday's lab, to play through these patterns one more time, like we did in class. Okay, I do it for them in class every week, because that little bit of a walkthrough opens the door for them to explore on their own. I think that's a very important thing. So we have a PNF app coming, the PEDS app. We have finished the medical screening app, filming it. We are now processing it. We're working on a wound care game because our NPTE scores on wound care are terrible, and I think it's because they don't get to play out their logic. So instead of building an app, we're going to build a game so they could choose to do the right type of debridement or choose the right type of dressing and be rewarded or punished game style, right? The way that they like to learn. We're doing a study looking at CIs and students and how these apps can bridge and be a part of the conversation in the clinical instructor and student experience. And I just want to actually open it up and get any comments or thoughts from you. And yes, Seinfeld, I would just say captioning is important. We have our own first deaf student or hearing impaired student. And that's a massive task, if you can imagine all the videos that we have, but it's something that we will be figuring out how to do this. So, but yes, let me open it up. I know we're over past time, but I'm free to chat. If any of you who still want to chat, I'm free to chat. But thank you very much, and please look out for an email. And if you don't get the email within the next 2 days, please email me, because all of you now have full faculty access. You'll be able to utilize this as much as you want in your classes. We hope to be able to support your students. Like I mentioned before, what universities do with us is they basically either send us their class list and we send them a special 50% off invoice. It's a one-time fee of $99. And they get all these apps and the future apps, and they can choose to buy it or not. They don't have to get it. It's just most universities are doing that for us, or we set up a Google Sheet. Any of the students who want to sign up, they sign up, and then we send them the invoice. They can purchase it or not. Again, we are trying to create if you think about all the classes that we're covering, $99 is a drop in the bucket. And they use this all the way through. I'm still using this to teach in residency and fellowship education. So I hope that's useful to you. Please, comments, questions, ideas. Any comments or questions or ideas that you guys might have. And make sure you unmute yourself, just in case you're muted and want to make a comment here.
Michael, I'll just say that we're looking at how we can thread the information through all of our courses.
Yes.
So at the intro level, they're getting just a taste, but they know where to go to get more information.
Yes. And I will tell you that will be a great conversation to have offline. I'd be happy to jump online with any of you at any time. I have time to do that, and I enjoy doing that. That anatomy series is one of the ways we're beginning to thread things. We're connecting it to range of motion MMT. We're connecting it anatomy or functional anatomy to ortho. We're connecting neuroanatomy to the neuro exam class. And so I think that is a very critical component of ensuring that there is this overlap and this bridge so that students don't feel like they just need to silo the information, dump it out of their head, and move on to the next class. So.
There's a question from GM12.
Yes.
Can we purchase this app as a university to use for all students?
Yeah, so hey, maybe you can speak into this. Some universities have purchased the apps for their students as part of the budget. So they basically send us a list of students at the beginning of their program, and we invoice them. So they have 46 students. Here's their emails, and we onboard them. So the students will now, as part of the program, will get their personal access. Now, you can see that if the university said, well, can I just buy $199 license and give the password to all of our students, what happens is the app will not function well when there's 46 students trying to log in all at once. And also, the little bit that we're charging supports all the filming. I pay every single student who is a model, the actors, the filmers, the editing, the computer programmers. All of that comes from this funding and all of my savings. And so, yet, I think we have, some of the things we've done is, hey, our university has 10 iPads. Could we just buy all of your apps on the iPads, and then when we need to, we distribute the iPads and the students can use it? I think that's fine. I know that our students are strapped for money, and this is a resource that eventually the students may want to get on their own, but of course the 50% off, the $99, is what the students would end up getting if they bought it and they have it on their devices all the time, instead of like, oh, I got to give the iPad back. But yes, we've done that as well. All you have to do, if your iPads are linked to your department account, you can just go and buy all the apps once, and all 10 of the iPads will have those apps. I think that's a great option already. So.
Another comments from Amanda. $99 is a great price. We have programs, iPads that I would like to have these apps installed, like this person is speaking of. Is there training or advice to incorporate this into more courses throughout the education?
Yeah, absolutely. So Amanda, one of these days, please reach out to me at mike@PhysioU.com. We can always schedule a half-hour, 45-minute chat just based on certain, to kind of customize these ideas. And I would say for all of the members who have joined us, or all of the faculty who have joined us, I think you bite off a little bit at a time. So you go, you know what? For my range of motion MMT class, I want the students to use this, and it's inevitably going to be a little bit different from how you've done it. So the decision you have to make is, do I like this resource enough to go with the resource or augment it a little bit, or not? And also, I think it's a useful conversation to give to us feedback as well. Hey, you know what? That's actually really kind of off. Could you refilm that because of this reference or that reference? We love that, because we're continuing to update the content. It's not like we printed 1,000 and we need to reprint it. No, we can just refilm it. So I think you bite off a little bit at a time. For the orthopedic musculoskeletal instructors, I recommend that at the beginning of every week, you take one or two common, like shoulder week, you take one or two common conditions and you play the app through together. Allow the students to get a sense of the lay of the land. Allow your expertise to kind of fill in the little gaps a little bit. And then say, I want you guys to play with it, and feel free to come back with questions. Let's discuss. Let's talk. This becomes a platform for a cognitive exercise that allows your expertise to really shine, I think. So you're not just stuck delivering the didactic content. So, any other questions? And please feel free, everybody, if you don't get the email from us in a couple of days, please email me at mike@physiou.com. And if you would like to chat a little bit more, or figure out how we can integrate this into your program, please feel free again to reach out to me, and then I'll put you in touch with Songhae, who's been helping us out, and she's been connecting with the bookstore if you want to go through the bookstore way, or directly through the student list, or creating a Google Sheet where people can sign up. Any of these ways are fine. So, any other questions or comments?
There's a comment from is it initial, so it's
okay,
just about.
Great.
This is great, and I can see that having something for students to go back to for review as often as they would like is vital to learning.
Right. Yeah, I think that's true, because they're thinking about stuff all the time, and then if you don't have a reference tool that they can get to quickly, that moment passes. Right. So, yeah. Great. Well, thank you, everybody. Thank you for being a part of this conversation, being a part of this new journey, looking at new tools for your students. I applaud you for that. It's a dream to be able to work with you and to serve your students and serve you as faculty, and looking forward to staying in touch. So please feel free to reach out to me at mike@PhysioU.com. Hope you guys have a great day, and stay in touch. We will have a few more webinars, particularly with the rehab, our neuro instructor, our cardiopulmonary instructor. I think this guideline integration is very important, clinical practice guideline integration, and we've built it into the apps. This is primarily for the musculoskeletal content, so that will be a few more that will be coming up. Please feel free to join us for those as well. And I'm really thankful that you guys took the time to see what we're building. And hey, play with it. Let us know what you think. Let us know what you need. We are invested in changing rehab education and improving the cost as well as the ability to deliver good evidence and meet the different learning styles of the students, this new generation. So anyways, thank you everybody, and have a great day.